Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Fardon, and I'm the chair and organizer of Grand Rounds. And it's with great pleasure I welcome Rory McCrimmon back to Grand Rounds today. He spoke just a few weeks ago in his role as the dean of the medical school, giving us his annual update of what's happened in the medical school, which is always one of the highlights, I think, of the annual Grand Round program. But I keep pestering him to come and talk about his other hat, which is as a professor of diabetes research here in the University of Dundee, and his specialist interest is type 1 diabetes. We heard Ewan Pearson speak about type 2 diabetes and the personalization of management in November of this academic year, but type 1 diabetes gets a bit more of a limelight today. I remember actually, Rory, when you first came here, you did a Grand Round, or maybe perhaps it was still called the medical meeting, where you came in to talk about your research. Was it Canada or America you've been? I have
America.
In my head. I remember you giving that talk and being very impressed at the time, and I'm thinking he'll go far, that guy. And there you are. But before we do that, I'm going to hijack the stream ever so slightly, because Ellie Hoddesall, who's the undergraduate lead for the MBCHB program, has asked me just to plug a few roles that are available. I've just recently been advertised in the MBCHB program, and they're all based around assessment. So they're looking for a year 1 and year 3 co-leads and a year 5 co-lead, and there perhaps are even more of those. So if you're looking for an expanded role, looking to do something different, looking to take on a role within the medical school or medical education more broadly, then those roles are available. Ellie would be very happy to speak to you. I can put you in touch with her, and I'd be very happy to talk about you as well with some of the experience I've had with in that area. So if you are interested in that, please let me know. Normal Zoom rules apply. Please mute your microphones until the end. If you want to ask a question, please put it in the chat or put your hand up at the end. And on today, which is the 3rd year anniversary to the day of the first lockdown of COVID, was at least one thing that has come out of it, which is positive, is that we can hold these meetings so seamlessly from somebody's front living room, my office, and wherever you are in the world through Zoom. So, Rory, thanks very much. Looking forward to your talk.
Great, thanks, Tom. So what Tom asked me to talk a bit today about some of the changes or advances in type 1 diabetes. And what I've done, there are a number of areas in which therapy has changed dramatically in diabetes, both type 1 and type 2, over the last 10 to 15 years, and particularly over the last few years. And I'm going to focus on some of the technological changes, because there has been an accelerated change, a lot of new insulins and a lot of new forms of pump therapy and continuous glucose monitoring that we're all beginning to see in clinical practice, and increasingly we'll see inside the hospital, and some sort of familiarity with will be useful. I mean, just as we're seeing ChatGPT and these AI systems now beginning to come into every aspect of our lives, particularly the university and everything else, they're also starting to inform the technology that we use to treat diabetes. And I have to say, for the first time in many, many years, I think we have therapies that are now progressing quickly to, particularly for type 1, a hands-off system, whereby glucose control can be maintained by, an AI system within a pump and within a sensor that actually enables good quality of care and takes the pressure and the burden off the individual. So I'm going to just broadly run through some of the areas that we see now, what's available now and what is likely to be available in the next couple of years. Some of the areas that I haven't addressed stem cell therapy, which is progressing, but much more slowly and in the background. And I haven't really discussed some of the adjunct therapies that are used in type 1 as well as in type 2 diabetes, where there's a place, but it's a place that's not yet established, for things like SGLT2 inhibitors or these dual agonists that you're probably all reading about in the paper and BBC as much as anything else these days, that are having such a profound effect upon weight, particularly again for obesity and type 2 diabetes. But the median BMI of type 1 diabetes is now 21, weight gain just as there is in the general population. And so we'll start to see these therapies used there as well. But still, focusing on today, well, we've moved on. We've moved along for a long way. I was looking a little bit in the past, and I was looking at some data from the 19th century in terms of the management of insulin. And these days, they had it right in some respect. It was opium, whiskey, and port wine. So that was what you got if you had diabetes in the 19th century. Before we got a little bit more frugal in our approaches. Around about 1900s, First World War time, Frederick Allen, who's pretty well established, funny enough, in the diabetes world, and introduced the calorie-restricted diet. And for many years, at the turn of the century there, that's what happened to you. If you developed diabetes, effectively it was going to be a death sentence. And they tried to put people on very, very strict calorie diets. They went off to live in the, if they could afford it, into the foothills of Italy to try and get better. And ultimately, ultimately they didn't get better, and ultimately they died, because without insulin, of course, type 1 diabetes is effectively a fatal disease. And then just over 100 years ago, there's some debate as to whether it was 1922 or 1923. The Aberdonians think it was 1923, but for the rest of the world, 1922. We discovered, insulin was discovered by Banting, Best, MacLeod, and Killip, all working together, for which MacLeod and Banting were awarded the joint Nobel Prize. And this is a really well-recognized figure in the diabetes world of a young boy who received the first injections of insulin. And here he is, no more than 3 months later, suddenly looking like a healthy young child again, compared to this almost skeletal form that you see on the left-hand side. So this was a tremendous advance. And at the time, people like Elizabeth Hughes were talking about now being able to contemplate a normal, healthy existence. And now, of course, we had discovered insulin. We hadn't quite discovered good glycemic control. And very clearly, what we didn't see was a normal, healthy existence for many people with type 1 diabetes. But in itself, of course, it was a tremendous invention. Now, since that time, of course, things have progressed, particularly in insulin therapy, which is where I'll start. 1922, we had Banting and Best isolated insulin. Then we moved on to the animal insulins in the 1920s, protamine zinc in the 1936 from Hangendorn from Denmark, NPH insulin in the 1940s, which was the first of the more intermediate human insulins that had been purified, and the longer-acting lente insulins in the 1950s. And these really, for the next 50 years, were pretty much the established therapy of choice. Well, the next 50 years in most parts of the world, but sadly in the NHS, they've continued even now to the 1970s. Then we got into the whole world of insulin bioengineering, and we came up with a recombinant, biochemists came up with recombinant human insulin, moving on to the short and rapid acting and the basal insulin analogs, which have really done a lot to improve insulin care, type 1 diabetes care. We've also seen an evolution in the insulin delivery systems. There is the old syringe gun on the far left-hand side, a sort of museum piece that we had, and the syringes. You can see we used to have reusable needles that had to be boiled at home, and people used to have these little stones to sharpen the needle prior to injection before the ultra-fine, microfine needle was developed, which many would also consider one of the major advances in insulin therapy, because once you develop these almost painless needle injections, it made the treatment of type 1 diabetes so much easier than the sort of very large, very blunt needles that people were using up until that point. And then, of course, the disposable cartridges that followed on from that. And again, this remained fairly standard of therapy, and in fact is still standard of care in many parts of the world and the country, including here in the UK. So what are we going to talk about today? I'll focus a little bit on some of the novel insulins. I think we need to be aware of that because there's an awful lot of novel insulins coming available. And so particularly on the hospital and in primary care, we're suddenly going to find this huge list of different insulins to look at and to try and understand how they work. So some broad understanding is going to help. I'm not really going to touch about the dual incretin therapies. They're mostly used or will be used for people with type 1 diabetes, although as I alluded to, there will be people with obesity and type 1 diabetes where we might consider these therapies and therefore consider how we might have to change their insulin management to join it. But the data is pretty impressive. The most recent tirzepatide, which is just been approved, I think, approved in the FDA, is causing 20 to 25% body weight loss. I mean, I think that's fairly dramatic, and we're going to see a huge effect. Then we have oral peptides that have become available and we're using locally with the oral version of semaglutide. Again, that's a tremendous advantage, being able to deliver a peptide orally rather than by injection. And then we'll talk a bit about some of the widgets, continuous glucose monitoring, smart friends, and a hybrid closed loop, which we're introducing or have been introducing over the last year here in Tayside. So why, and what is the benefit of these newer insulins? Well, effectively, as you develop a basal insulin, in the ideal situation, what you were trying to do is you were trying to have an insulin that has a longer and more predictable action. And you're trying to introduce an insulin that is less variable, so the peak to the trough ratio is reduced. And hopefully that will reduce hypoglycemia, particularly nocturnal hypoglycemia. Now, in this study from Tim Heiser's group a number of years ago, looking at NPH here in brown, glargine, lantus, effectively in this mauve color, and insulin detamir, another first-generation basal analog, in green. These are 3 individuals who've taken the same dose at the same time on 4 different days. And what you can see, particularly with the NPH, is that it's incredibly variable. Same dose, same time, 4 different days, and each of these profiles is hugely different. And so that makes it very difficult for people with type 1 who may eat and do the same thing, take their injection at the same time, and yet a completely different result when they look at, they say, their fasting glucose the following morning. The other difference here, as you can see, for instance, looking at this middle chart, the difference between the peak and the trough is really high. And the higher your peak insulin, of course, the bigger the drive to push your glucose down. Now with NPH, which was largely taken at nighttime, 9 or 10 o'clock before bedtime, with a peak at about 6 to 8 hours, well, that's 4 o'clock in the morning. So for you and I, or people without type 1 diabetes, when our insulin levels drop overnight, if you're on NPH, that level is going up, but it can be very, very high. And that, of course, pushes or drives nighttime and nocturnal hypoglycemia. It's one of the reasons I really think we should be minimizing the amount of human insulin, NPH type insulin, like human and I, we actually prescribe, and we prescribe a lot of it. We're one of the highest prescribers in the world in the UK. Now, in contrast, if you look at the first generation basal analogs, they're starting to be much more predictable in terms of their injection, their insulin profile over a 24-hour period, and the peak to trough ratio is now much lower, meaning that they're safer. And certainly in clinical trials, which I'll show you later on, there's reduced hypoglycemia rate. Then we have the second generation insulin analogs. The 2 are degludec or glargine U300, and now they're even flatter and even nicer profiles. So if you look at them over a 24-hour period, you don't see much variation in the insulin level. And as you up the dose, you see a nice predictable increase in that insulin profile. So again, reduced variability, reduced peak to trough ratios, and less hypoglycemia. And the trials show that. So this is a quick meta-analysis from a number of different trials showing here for either glargine U300 or degludec that you're getting a relative risk reduction, particularly in nocturnal hypoglycemia, from anything from 25 to 40% or up to 50%. So much, much safer insulins. Nocturnal hypoglycemia is where at least 50% of severe hypoglycemic episodes occur. That's hypoglycemia sufficient, and so you need external assistance or you've lost consciousness. And they're obviously greatly feared by people with both type 1 and type 2 diabetes, both of whom show similar benefits with these drugs. Now we also have coming is the once weekly insulin. These are going to be a really interesting thing to get hold of because that has huge implications actually for both hospital admissions as well as people with type 1 and type 2 diabetes. So these insulins have a very, very long half-life. There are 2 that are currently in clinical trials. There's icodec that is just about to report its first phase 3 trial, and there's Efsitora, it's a lovely, they come up with some beautiful names, Efsitora from Lilly, which has a half-life of 13 days. It's a very, very, very long insulin. So it can be injected once a week. That brings with it, and you get these very, very flat profiles now with peak to trough ratios, which are just above 1, which makes them really quite safe in some senses, although again, persisting for a very, very long time. And we can talk about the advantage. The advantage clearly is in compliance. If you're only taking insulin once a week, you're more likely to take it than if you take it once a day. And I think that is certainly a benefit, and it's certainly far more predictable. The issues are going to be, of course, well, what happens if you have surgery, all right? Or you're admitted to the hospital with severe hypo and you have an insulin that's going to take 7 days to clear from your system, or if you undergo a prolonged fast. Also, your dose changes is going to be very different from, rather than the typical change of 1 or 2 units at a time, you have to change by 7 or 14 units at a time. And you actually have to give a priming dose, a double dose to start off this therapy. And it takes up to 5 weeks for the dose to stabilize. So an entire culture shift and mind shift is going to have to come into us as we use these insulins. So this is what you might look like, a sort of a picture, a rough cartoon of what these insulins might look like. So this is glargine, which is by far the commonest first generation insulin prescribed worldwide. And this is what it might look like over a 24-hour period. So you still get this peak trough change. You still get around about a sort of 8 to 10 hour peak after injection, actually sort of 6 to 8 hour peak, lasts for just under a 24-hour period. So many people with type 1 used to take this glargine twice daily. Whereas in contrast, now if you're looking at Icodec or Efsitora, now these are very, very flat and very, very long-acting insulins, which, as I've said to you before, there are pros and cons. Many positives, I have to say, I think, with these coming forward. This is a phase 2 study, not a phase 3, a phase 2 study that came up as a treat-to-target study with Icodec against glargine, both very effective in terms of lowering HbA1c to a target of less than 7%. Here, the Icodec in blue and the glargine U100 in gray, and a high percentage of individuals getting to targets of less than 7%. And here you're seeing very similar effects on the profile throughout both of them, and there were no significant differences in risk on rates of hypoglycemia or incidence of hypoglycemia in this 26-week trial. And actually achieved with a lower total daily dose, if you average it out, of the once weekly versus the once daily insulin. So that's the basal insulin analogs, and I think we're going to start to see the introduction of these once weekly, either on their own or part of what we call a fixed ratio combination with a GLP-1 receptor agonist, particularly I think in type 2 diabetes, although we might argue that they have a place in type 1 as well. We're also now developing rapid-acting insulins. We've sort of got used to Humulin R for many, many years, and eventually this evolved up to Lispro. Humalog is one of the first rapid-acting insulins, and now there are new, faster-acting insulins coming available. Thiasp is the first that we're sort of using occasionally clinically, and there's new rapid Lispro coming available for use clinically as well. What we're trying to here is to copy, if you like, human physiology. So here I have in green what happens if someone without type 1 diabetes has a meal, and you see this rapid first phase response in insulin, and then you get a prolonged second phase coming through. The fast-acting human regular insulin didn't match this at all. Interesting enough, for those who want to pay attention, all hospital sheets which we have, you go around the hospital at the moment, there's those pink sheets that we have for people with diabetes. They're all based on human soluble insulin, which almost nobody takes now. So I go around often with the trainees, I'm saying to them, well, they're frankly useless because they don't actually tell you what you need to know for rapid acting insulin. All they tell you about is your background, your basal insulin, we should probably monitor in a slightly different way within the hospital. But you can see the problem with the old human regular insulin. It lasted about 4 to 6 hours, which is why people had to snack all the time, because 2 to 3 hours after a meal, you'd have very, very high insulin levels, and that would cause a risk of hypoglycemia. As we've developed these more rapid acting insulins, we've shortened this time action. So the new very rapid acting insulins only last over 1 to 2 hours. And that more matches your carbohydrate intake, and therefore your risk of hypoglycemia is an awful lot less. So here is the Pronto type 1 study, which is just looking at the rapid acting insulin Lispro. Again, these are non-inferiority trials, so simply trying to show that they work just as effectively. The mealtime ultra rapid acting insulin here is in terms of the red line. The gray line is your standard Humalog Lispro that we have available. And here is just what happens if you take it post-meal. So these insulins offer up the opportunity for you to inject after a meal. Useful if you go to a restaurant, useful if you're not feeling well and you don't know how much you're going to eat, that you can inject afterwards. They still don't work as effectively as a pre-meal injection, but also can be taken immediately before a meal, whereas I think insulin analogs at the moment need to be taken about 20 to 30 minutes before you eat for you to see the best form of effectiveness. So it simply makes it more convenient for people with type 1 diabetes. And this is simply looking at the glucose profiles. Sorry about this, it's a busy sort of slide, but if you just focus on the middle slide here in terms of their profiles, what you can see in gray here is standard human log. So again, after a meal, you're still seeing this prandial rise going above a glucose level of 10, despite taking the optimal dose and for your carbohydrates, and these carbohydrate profile lasting for up to 3 hours. Whereas with this very rapid acting insulin in the red here, you're seeing that peak glucose is being reduced now to less than 10, which is where we want it to be. And actually that profile is fitting much nicer. You can also see here why there may be a risk, of course, because of this dip where post carbohydrate load, you're actually lower than you were beforehand. And therefore, there is a risk of early hypoglycemia, particularly in people who've got disruption in gastric motility, such as gastric paresis, which we'd need to watch out for. So the novel insulins, what opportunities are there for innovation? Well, for the rapid-acting, ultra-rapid-acting insulins, they're particularly good for the UK because we tend to love our carbohydrates in the morning. And, you know, cereal and milk is one of the classics. It's full of sugar, and that tends to cause quite a big peak in your glucose levels. So it could work very, very well effectively for breakfast time. Could work very well for people with new type 1 diabetes who've got endogenous insulin production, who'll do well with this type of rapid-acting insulin. Work very well for adolescents who tend to have a very high carbohydrate diet. With a high carbohydrate diet, particularly with simple sugars, these will work well to control that. The next good area is pump therapy. People may not know this, but actually pumps, because it takes about 90 minutes for a change in the infusion rate in a pump to actually change your insulin levels and systemic circulation, they're actually not as good for your mealtime insulin as an injection is. And so by having these very rapid acting insulins, you might actually improve that. And then, of course, in DKA management at home, you can be less worried about stacking with some of these rapid acting insulins. And so you can advise people at home to take multiple doses every 1 to 2 hours for rapid acting insulin to treat the DKA rather than necessarily coming into hospital. But the once weekly insulin's persistence and adherence, absolutely. Almost every trial will show you that the fewer medications you take and the less frequently you have to take them, the more likely you are to take them over time. And the adherence to once daily medication, particularly, for instance, the GLP-1 receptor class, at 1 year is probably about 50 to 70%, despite the benefits in terms of weight loss. So these once weekly insulins are likely to be taken much more regularly. You're reducing from 365 to 52 injections a year. It's probably more simple. You don't need to monitor as often. You can just take it once a day. In type 1 diabetes, I think there is potentially a case for recurrent DKA, or if your HbA1c is above 75, because we know such individuals are simply not taking their insulin. And so it might be this way of ensuring that there is some insulin on board throughout the time to at least prevent DKA and leave an individual with moderate glycemic control, because life has become so overwhelming that they're just simply struggling to take their insulin on a regular basis. Is there an argument, if you lessen your HbA1c titer, so you're less strict in control, of using this in the frail and the multimorbid? Because if you can inject once a week, then the district nurse only needs to go once a week rather than to go out once or even twice a day. And that would actually be a huge saving to society. And if it can be done safely, a lot easier for the patients and for their families. But of course, there is this risk of hypoglycemia, and we need to know more about particularly the risk of prolonged hypoglycemia with fasting, if you're admitted to a hospital for surgery, or through exercise. Last thing, just to let you know, there's been some work on what are called glucose responsive insulin. So if you look at this figure up on the top, what you have here is a glucose binding molecule here in the central figure in gray. And these are little molecules of glucose, if you like, which they bind and they displace insulin. So the more glucose you have, the more insulin you displace. and this is called glucose responsive. There are a number of these that have been trialed, although it's clear to me that they haven't quite found their place in the market and their niche, because they sound very attractive, but they don't seem to have translated that into clinical use and clinical benefit. But the concept is a pretty good one. So just as there have been advances in diabetes and in the insulins that we have and that we'll start to see in clinical practice, there's also been a huge number of advances in terms of our diabetes management systems. And we have gone from simply, for instance, in urine testing to blood glucose, finger prick testing to continuous glucose sensing, which is now dominant. Almost 70% of people with type 1 diabetes are on some form of continuous glucose monitor. And I think if we had our way, everybody would be on them. And actually one area which might come up afterwards, but an area we haven't addressed here is in hospital care, because, you know, rather than someone coming in for surgery and getting their finger pricked every hour for 48 hours during a surgical procedure, why on earth aren't we thinking about using continuous glucose monitors or continuous ketone monitors in HTU with someone coming with a diabetic ketoacidosis, which may need to be validated, but ultimately might be far, far easier and save people time within the hospital. In terms of insulin delivery systems, we've moved from these massive pump on the back, the famous picture from the 1960s, towards newer insulin pumps and the artificial pancreas project, which I'll show you a little bit about in a second. So this is what we had evolved from. We evolved from urine testing to the classical little book that we used to see in the clinic. And people would come in with their book, their insulin dose would be written in, the date would be written up, and the glucose levels throughout the day. Often using the same pen in the same color and probably all written the night before because it was a bit of a burden. And we'd be doing these little finger prick tests, and people would be sometimes very, very good at doing finger prick testing and sometimes very, very bad. It's quite uncomfortable, it's quite painful, and obviously nobody wants to necessarily do this in the long term. But that was standard for many, many years. Now what we have is a new world. We've gone, as I said, from looking at snapshots to looking at the entire movie in terms of someone's glucose control. And this has been truly, truly transformative. And it's actually something that came out of COVID, because during COVID, where we were doing so many virtual clinics and this type of monitoring become available, we were literally just handing this out. And almost 70% of people with type 1 are on this technique. So this is the initial form of the Freestyle Libre as one example of glucose monitor, which is the most popular, where people would simply scan their arm. Really simple to do. You put one of these on, they're on for 2 weeks, you just scan your arm. You need to do it a few times a day because there's only an 8-hour memory, but it would be able to give you this type of picture that you're seeing here, where you're really seeing someone's glucose profiles throughout the day. You can see where their median level are, you can see where their ranges are, you look at their profiles on different days of the week. If there are concerns about problems with glucose overnight or during the day, you can see exactly what they are and you begin to address them. This has also brought with a new way of looking at glucose control, something called time in range. And I think it's a really intuitive thing, so much easier than HbA1c, which was an abstract concept that most people didn't understand. They'd come to the clinic, just know what their number was and think it's good or is it bad, but it doesn't tell them very much about their control. Whereas now you can look at this, and we look in time in glucose target range of say 4 to 10, which is in the green, and we're trying to get a target range of 70%. But intuitively, you can see, well, 50%, 5% of my time in target, 24% high, 6% low, and 4% very low, which we want to avoid. And that also gives an idea of someone's glycemic variability. Are they someone who's maintaining their glucose very, very well within a reasonable range, can give you a good HbA1c, or are they still got a good HbA1c, but actually very, very variable, which is not good. That causes a lot of tissue stress and potential damage in the long term. So as I said, this has transformed clinics. And of course, you can post this online. So I can be doing a virtual clinic with you pretty much anywhere, and I can pull up through, say, LibreView platform and look at your continuous glucose profile over the last sort of week. So a fantastic educational tool, I think. And they work effectively. So this is a Diamond, which is a randomized clinical trial of people with type 1 diabetes looking at CGM versus controls. And you see this entire left shift in the number of people achieving an HbA1c of less than 7 or less than 7.5%. So it improved overall glycemic control when used. And in Scotland, we're fortunate to be able to use our Scottish data to collect information on all people with flash glucose monitoring in their community. And what you were seeing here, this work came from Helen Colquhoun's group. Fraser Gibb was leading on the work. And what you can see in red is if you look at users of flash glucose monitoring, this is not a clinical trial situation, it's sort of real world data, you see a population change in HbA1c, and that has long-term benefits to the NHS, of course, through improved glycemic control. This again, apologies for it's a bit too complex a slide, but if we, what a simple message here is that flash glucose monitoring was also shown to reduce the frequency of diabetic ketoacidosis. Here in this top left, looking at the events per year among different age groups, you can see a reduction overall in the number of DKAs, diabetic ketoacidosis experienced in people on pumps, and that was irrespective of age, sex, or socioeconomic class. So not only improving HbA1c, but reducing DKA emissions, which are one of the major costs associated with type 1 diabetes, and of course one of the major causes of death in young people with type 1 diabetes. That's in the general population. When you look at specific groups, and in hypo-DE, they were looking at people with impaired awareness of hypoglycemia, the most at risk. And here they're using real-time continuous glucose monitoring now. Now, this is different from flash glucose monitoring in that real-time is readily accessible, for instance, on your phone, but also has alarms warning people when your glucose level is dropping. And what hypo-DE showed in this follow-up, if you look at the green bars from baseline to follow-up period, you see a marked reduction in the number of severe hypoglycemic episodes with continuous glucose monitoring. And that's been consistent over a number of different trials now. Alert 2.1 is another trial which is showing exactly the same thing, but this time comparing intermittently scanned, that's flash glucose monitoring, with real-time continuous glucose monitoring, and again showing a reduction. I'll just show down here in the bottom right-hand here, a reduction with real-time continuous glucose monitoring the number of severe hypos. So that's where the alarms come into play, so they can actually help people, waking them up through the night or telling them the glucose level is going low and they need to do something about it. And so finally, this classification, or this means of assessing glucose in terms of time in range, has now become really pretty widespread. And as I said, simply because it's so intuitive. And although it's not linked with any clear and obvious long-term outcomes yet in the way that HbA1c was, I mean, effectively it is telling us the same thing. And so there are guidelines for people with type 1 and type 2 diabetes, how you might change when people are older or in pregnancy or with gestational diabetes. So what is the future in this area? Well, the future is here. It's a bit of a slogan, but it's right. It's simpler, smaller, and smarter, i.e. can we get our sensors to be much, much smaller, so they're less intrusive, less obvious and more discreet? Can they be simpler in terms of the diabetes management system, so that we can take a lot of the guesswork and the complexity away from the individual diabetes and put it within a computer-based system? And can you also develop predictive analysis saying, well, to an individual, you had a lot of low-level hypoglycemia last week, you're much more at risk of a severe hypoglycemia next week, contact your healthcare professional or think about what your insulin doses are. And I think these are going to be really nice to see if they do come into fruition. A lot of people are working in this space. So what do the smaller ones look like? Well, it's hard to tell. It's an American coin study, but the new Libre 3 is about half the size of the current Freestyle Libre that many of you have probably seen in times of use. So much, much, much smaller, around about the sort of size on that people wear in the back of their arm. Also more accurate with less variation compared to blood glucose sensing, about 9% variation compared to, let's say, a formal blood glucose, which is pretty good, really. It can also store data for up to 14 days. So you don't get the data gaps that we used to get with the systems that were on for just, you could only store data for up to 8 hours afterwards. And the Libre 3 now is moving towards having optional glucose alarms, because they can link it up with your phone. So now it can tell you whether you're having a hypo or not. Similarly, the Dexcom 7, and this gives you a better example about how things are dropping. This is a continuous glucose sensor that is worn often in someone's abdomen. The new form, the 7, is about half the size of the Dexcom 6 and the variations before that. It links directly with your Apple iWatch or with your phone. And in the US, they've got them now linking to the screen on your car dashboard, which will tell you where your glucose level is, and most importantly, whether it's going down or whether it's going up, and therefore whether you need to make a change. These have a very quick warm-up period when you put them in, and no calibration is needed, which means you don't need to do a finger prick test to calibrate your continuous glucose sensor when it goes on. And then finally, released in America recently, which is fascinating, is a glucose smart watch. We don't know much about this clinically and how it works. And you've got these little fine, very, very small sensors on the back of the watch, which sits on top of underneath the smartwatch, if you like, on your wrist. And of course, these smartwatches now have your O2 sats, your heart rate, and your exercise and everything else in front of them. So it will be fascinating to see whether actually a sensor you can accurately have a sensor on your arm as part of just wearable tech communicating with your phone, because that in itself will be a fantastic advancement. And then this other one, for those people who don't like wearing watches and don't like wearing sensors, they have an implantable continuous sensor which lasts for 6 months, and they're developing one that may last for about a year. So this little capsule pops under the skin like the old testosterone inserts we used to inject in endocrinology many years back, and will give you continuous glucose reading for the next 6-month period. So interesting how they work. And we also have what's coming as smart pen. Technology gets everywhere. So what happens here is effectively you take your standard pen, and within your cap, you've got a little computerized system which is able to link up with your phone. What it will tell you is exactly when you inject. So you can now have a continuous profile. You record through your phone exactly when you've injected. And of course, it's a memory phone, because a lot of people forget they've taken their insulin. They can't remember whether they took it the night before or whether they had it in breakfast 1 hour ago. So now you've got a system which is telling you exactly what it is when you injected and what that link was with your glucose profiles afterwards. The smart pen will also tell you how much insulin to give, because most people can't do the math. And what this figure is telling you is that if you take people who are carbohydrate counting and ask them, based upon their insulin to carb ratios, to calculate the amount of insulin they should take with a meal based upon the carbohydrate they're about to ingest, 63% of the time they get it wrong. Whereas, of course, if you use a smart pen, only 6% of the time you get it wrong. So if you want to improve the math and get the insulin dose right, give it to a computer. Don't give it to the average person out there with diabetes, I'm afraid. And there are now a huge number of apps available on phones that people can have, and which all have been shown to improve control in people with type 1 diabetes, simply because they're getting the insulin doses right. So that's for those people who have these separate systems. But of course, we want to combine those systems. And we're combining them now within the pumps and with the artificial progress. And these are just some of the pumps that we have available. The Medtronic pump, the Tandem pump, and this is the Bionic Pancreas, which is both insulin and glucagon infusions. And as I said, beautifully named, the Bionic Pancreas. Overall, pumps have been shown to improve the level of reduce the risk of hypoglycemia. Data is a bit mixed, but pretty reasonably strong. Data is less strong in terms of HbA1c, largely because most people who were getting the pumps had good control to start off with. This is what the system is looking like, just to sort of orientate you, the different paths that it's come from. This is someone with a pump with this classical giving set. This is your sensor that is plugged into the abdomen. Here's your iPhone, in which case there's a personal management device within that. Your sensor communicates to your iPhone to your pump, and your pump automatically adjusts its background rate. And that's the principle of the artificial pancreas. Things started out, first of all, with something called low glucose suspend, when these were coming together. So what they did was they particularly worked overnight, where you would have your sensor communicate to your pump, and if your glucose level dropped overnight, what would happen is your insulin pump would be switched off, and you wouldn't be getting any insulin. And that was shown to reduce the risk, particularly of nocturnal hypoglycemia. So if you're looking at median sensor glucose, over this sensor, you can see as you drop into nighttime, you're seeing that the sensor glucose is now rising up because it's dropping, it's sensing lowering glucose levels, whereas in your control situation, it stays quite low. So the number of nights with low glucose are far lower in your intervention and your control. So that was a tremendous advantage, just simply by reducing nocturnal hypoglycemia. It made a big difference, and it brought a lot of confidence, particularly to parents of children. Remember, parents were getting up every single night of the year for their child with type 1 diabetes, often 3 o'clock in the morning, to measure their glucose, to make sure they weren't having a severe hypo. Now you have a system where you know the insulin pump is going to shut off, and you know that there will be an alarm that's sent to you, because you can send it to your parents' phone by the side of your bed to wake you up if your child is having a hypo. So now you can have a good night's sleep. And that makes such a difference to people's lives. Moving on from the low glucose suspend was a predictive low glucose suspend. So rather than wait until your glucose level was low, it would sense when your glucose level was coming down beyond a certain level, and particularly was falling quickly. And then you'd shut off your insulin infusion, and that would allow the glucose to recover, because again, it takes 90 minutes for this change to happen. So you want to be predicting it rather than waiting until it happens. And then we've moved on to what's now called the hybrid closed loop. We haven't gone to the full closed loop system, we've gone to the hybrid closed loop, and that's really looking after your background insulin, if you like. So effectively, you have a hands-free system where your sensor is communicating to your pump, and it is managing your glucose on a minute-to-minute basis. Every 15 minutes, your insulin infusion will change based upon your glucose level. And all you do as a person is you come in, and when you have a meal, you're going to bolus, or when you eat. And if you do something like, say, exercise, you might temporarily reduce your rate. So it restricts your involvement to times of carbohydrate or times of change, such as exercise. And this has been shown to really improve control. And the reason I show this particular chart, because if you look at the UK as a whole, we generally give pumps to people who've already got very good control, because they get it because they know how to ask for it. They get it because they're having issues with hypoglycemia. But generally, they have very, very good control. But here we have a group of individuals who have poor control, HbA1c above 9%, above 75 millimoles per mole, who we know are the major cause of hospital admissions and diabetic ketoacidosis, and the major cause of complications. These are many people who are simply not taking their insulin on a regular basis. And because of that, they tend not to get the insulin technologies. And yet here we have a clear example that it works. You take the pressure off, it works. And what you're seeing is, even if these individuals are not taking their mealtime insulin, you're still seeing a real improvement in HbA1c to levels of about 7.5%, which is fantastic, really, compared to where we have come from. And what this is a study comparing the different technologies. On the left side here, the sensor augmented pump. And the middle one is a predictive low glucose suspend. And here we have hybrid closed loop. And in each case, what you're seeing is a progressive improvement in what we call time in range. With the target, I said, the ideal target being greater than 70%. So pretty much getting there with hybrid closed loop system, although this was a single center cohort study, and so not a classical RCT. And to give you an example here of the sort of things that you see, now this is an automated basal system. These are the glucose profiles with the artificial pancreas, the fully closed loop system in blue, and the control classic insulin pump in red. And what I really wanted to focus on is apart from the fact that you're keeping it with the AP system, blue, you're staying within this really tight glucose range of about 4 to under 9, which is physiological effectively. Look at the number of changes that you see in that basal rate. It's changing multiple times here in blue throughout the day in order to achieve that. Now think about what we're doing. We're giving people a once a day or a once a week insulin with no change whatsoever. Or we're giving them a pump and changing their rate maybe 3 or 4 times a day, sometimes maybe 5 times a day. And yet what you really need to be doing is change it on a massive basis. And you can't do that without the technology, but that's what these systems now offer. And then finally, what we have is the bionic pancreas, is where now they're combining insulin and glucagon. Remember, in type 1 diabetes, you have both loss of insulin secretion, but you also have a defect in alpha cell glucagon secretion because of the loss of this beta cell. And so, in fact, we know that glucagon secretion is abnormal in type 1 diabetes, that they don't secrete the glucagon in response to hypoglycemia. And they actually have a slight rise in glucagon with meals before it falls. So it's also abnormal. So these pumps are designed to address that and particularly reduce hypoglycemia frequency. And early trials to date, the first trials were quite promising. Good improvement in HbA1c, reduction in hypoglycemia. A large RCT reported a few months ago actually showed no difference in overall hypoglycemia. So there's a bit of work to be done there, but it's an interesting therapy that again is just adding into the options that we have available. And this is just showing on the left side here the reduction in hypoglycemia rate, particularly over the nighttime, in adults with type 1 diabetes on the bionic pancreas. So this is the artificial pancreas project that I've been telling you through, going from the very low glucose insulin suspend systems towards a fully automated multi-hormone closed loop. And actually, we're already pretty much implementing at stage 4 here. There are randomized clinical trials out there now being reported and completed with fully automated insulin closed loop. So we're getting very, very close to this sort of area. We're still giving insulin in the wrong place, but the advance here in this last 10 to 15 years has been really quite fantastic, which I think will make a huge difference in people's lives. Of course, we've got to give it to them. And this is where we are struggling. The NHS, of course, has no money. We have about 12% of our population with adults with type 1 diabetes on insulin pumps. Kids, it's nearly 100% actually. And I think it's something that we need to be pushing much harder for. But of course, there is a short-term cost at a time when the NHS is not flush and doesn't have much money. And so we need to think about how we can use this in a way that is cleverer, how we as a group can show the financial impact in the longer term of good glycemic control with these newer systems, both keeping people in work and keeping people out of the hospital, which is absolutely to the benefit of the long-term benefit of the NHS. But of course, that would require an NHS that thinks beyond the end of the financial year, and that's always a bit of a challenge. We need to remove obstacles to access. And in here, I'm afraid, I think we can be a barrier to other. We're so focused on equality, we tend not to think about equity. And so we offer equal access, which means that many people don't get access to the therapies that we have. And we put obstacles in the way. We look to try and ensure that we're giving the best possible treatment and that people are the best possibly educated in terms of, say, being able to carbohydrate count perfectly, be able to do X, Y, and Z perfectly, because we want to get the best use out of the pump. But actually, maybe we just want to give somebody a hybrid closed loop because it's going to work and your HbA1c above 9%. You're not going to carbohydrate count, we know it. You're probably not going to take your mealtime insulin, and we know it. But does it really matter if we can get your HbA1c from 75 to 55? We're going to dramatically reduce your risk of hospital complications, and we're going to keep you out of hospital. And until one day when you're in a better place and you're able to do the carbohydrate counting, well, isn't that a big achievement in itself? And yet we're not really allowing people access to that. And if you look across the UK as a whole, the average HbA1c in pump initiation is very, very good already, because we're giving it to people who've already got good control and they get slightly better control. And they're almost always in the higher socioeconomic classes. So those in the lower socioeconomic classes are not getting the sort of therapies that I think that we need to. We need to think also about where it gives the third sector. There's a really good third sector out there. We don't use them in the NHS, and yet we're short of nurses and we're short of doctors. And so we struggle to deliver the sort of service that we want to deliver. And so maybe we need to think differently. And then finally, we need to, as I said, we are contributing to the problem, I believe, and we need to ensure equity of access, and we're not ensuring equity of access at the moment. And here's an example of it. I just look here at the this figure on the bottom hand right, looking at HbA1c levels over time. We've got slightly better in Scotland, but here is your socio-economic classes, from the highest to the bottom to the lowest in the red at the top. And this is your HbA1c over time. And you can see there's a very, very clear divide between each socioeconomic class and the sort of HbA1c people are achieving. So we need to, this red bar is not good. These are lower socioeconomic class individuals with the worst control, the highest risk of complications, the highest risk of admissions. We want to reduce cost burden to the individual and to the state. We've got to deal with that. And I think for the first time, we do have therapies such as hybrid closed loop and even once weekly insulins that are really going to make a difference there. So what's coming up? The last thing then, sorry to keep you so long. What are we going to get? Well, we're going to get mobile bolusing from the phone rather than from having to use the pump itself, which I think is a great advance. The pumps themselves are going to get smaller as well. So the Tandem Mobi is about 50% the size of the T-Slim, which is already a small pump, but I think that's great for system. The Omnipod, which is a different type of pump, is called a patch pump, which goes straight onto the skin as opposed to having the tubing. They're now coming in with their first closed loop system, which is just being approved in America and the FDA, and we might eventually get it here. There are new sensors coming out, as I showed to you earlier on, like the Dexcom and G7 and Freestyle Libre, which are not smaller, and the Eversense 100-day implantable. And that we're extending the infusion sets with Medtronic. So rather than changing your pump infusion set every 3 to 4 days, now every 7 days. So again, that's much better for people. And there's another connected pen coming available. I think the connected pens are proving to be really interesting and useful. So there you go, a quick fly through the different technologies that are available, and it'd be interesting to listen to if anyone have any comments, because clearly we're going to see quite a bit of this in the hospital in one form or other, as well as in the community. So thanks for listening.
Thanks very much, Rory. I mean, really incredible. And you started off. You said you'd start off with Banting Invest, and you did, and the dog and etc. And in a short time to go from that to Bionic Pancreas is and let's face it, most of that advanced, those we've seen a lot of that in the time I've been qualified, and it really seems to be an exponential change. When I think back to medical school, we were just talking about Humalog, and even as a SHO, that's what I learned is, add things up, divide by weights, divide it by 9, and whatever it was we did. So I think this is amazing stuff. Now, there's a number of learned endocrinologists in the audience who may have some comments. There are plenty of other folk who may have a comment. Nothing in the chat as yet. Do put your hand up if you have a question, or just slip it into the chat.
One thing to say, Tom, is that with all these insulins, of course, there is propensity for risk, particularly in the hospital, because you can confuse it, and it's happening. You can confuse U100 and U300 insulin. You can confuse a once weekly insulin with a once daily insulin. So we're going to have to be really, really careful about this. And of course, if someone comes in on a once weekly insulin into A&E with, with a severe hypo, or ready for surgery, you got to be aware there's something that's not going to go from their circulation for the next few weeks.
Indeed, and Dave and I were just commenting during your presentation about how, with the weekly insulins, how would we try to protect against overdose?
Yeah, I think
how many doses
overdose can happen, and at some point, of course, it's going to happen, and we're going to have to learn about how we deal with that. I mean, I think when you're getting down to a peak trough ratio of 1. All right, so F Histora is 1.14, which is really impressive. That's like basal insulin. And remember, you and I have basal insulin. We produce it all the time. Now, it's still giving it in the wrong place. So it's about 50% more, because about half about 50% of your insulin is metabolized by the liver. And so you're still hyperinsulinemic, even with that sort of fantastically low level. So it's something we've got to be really wary of. But yeah, you're right. I mean, how do you deal with an overdose? Because it's not going to go away for a long time.
There's no other questions as yet. One of the other things that maybe perhaps just talk more broadly, and you did talk about the socioeconomic divide at the end there.
Yeah.
Over the pond in America, insulin costs an absolute fortune, and we hear a lot of things, and I don't know the truth and veracity of it, but we hear stories of people rationing out their own insulin because they can't afford to go and buy it, and the price is being ramped up by pharmaceutical companies, and this differentially affects people from poorer backgrounds. Obviously, we have prescriptions for free here, but have you just got any general comments about that? I think it's
I mean, you know what? I'm presenting to you data. These are first world issues, right? I mean, these are not third world issues. And I have presented to the students, because one of the talks I give to the MBCHP students is around global inequalities of access to insulin. Now, Novo Nordisk reduced their price of insulin in America by 75% 2 weeks ago. Last week, the announcement came out, following on from Lilly having done the same thing, and that because of huge pressure from Joe Biden, and because people were going across to Mexico to buy insulin. They were rationing out their therapy. It was a major problem for them, and so they have done that because America does pay full cost price. It's expensive, but actually in the third world, I mean, we're talking about pumps in the third world. The issue is about access to insulin at all, and so that's one of the major problems. The cost of insulin is expensive. And I think the cost has to be brought down. People argue it's manufactured. There are a lot of people now who are trying to non-profits, both in California, you'll be aware there's a company that started, as well as, in fact, here in Glasgow, where they're trying to produce insulin in a different way that is cheap and that can be used in the third world. And that in itself would be amazing and a really important innovation.
Absolutely. There is a hand up. Are you brave enough to turn your camera on?
I'd like to turn my camera on, but I'm not feeling too great with COVID at the moment, so I'm just...
Oh, well, I think that's very reasonable.
Rory, thank you for that. It's Icky here. Great overview, as always. I think you've hit the nail on the head. It's partly comment and partly just to update you as well. I think we've been guilty as healthcare professionals of targeting, the people that come to clinic, the people that go to HbA1cs, and they're the engaged ones, but you're right, the recurrent DKAs, the high H1C, the SMD classes. And what we've done is we've put too many barriers in place. We've discussed this before in the past. So you'd be pleased to know that we've had a meeting in the last couple of weeks, and I'm actually redrafting, and I've slashed away many of those barriers we talked about to try and create a new pathway for pump and CGMS in our type 1 patients. So I'll share that with you at some stage, but I think you're absolutely right. And I think I've been having chats with Fraser Gibb and people in Aberdeen as well. And we should try and come up with a Scotland-wide approach, because as you say, it's about equity, not equality right now.
Yeah, and it's not just us in diabetes. I mean, Tom, we've probably talked about this in the past, but frankly, it's everywhere in the NHS. And if you look at the inequalities in access broadly, it relates to far more than just diabetes care. I think across the NHS as a whole, we've got to think about what it is we're trying to achieve and how we are able to target groups who aren't necessarily able to articulate or ask for what they want, and or who live in circumstances where it's going to be incredibly challenging for them. And so what is it we want to achieve within that group? Is it perfection, or is it actually just, a slightly better or an easier life for them? So I think that's what we're going to look at.
Thanks very much. Okay, the clock is ticking over towards 2 o'clock and people have things to get to. I'm just going to share the QR code, he says, try to find it. So if you want to scan this here QR code here, that will take you straight to the form that we've generated. I say we, it's the DME office that have done this. And that will allow you to put in your details, put in the titles of today's talk, and you will very quickly be emailed a certificate to say you were here, whether you were here at the time or whether you're watching this on YouTube later, you still get the same certificate. And that also lets us know who comes to these talks, who listens and watches them afterwards, and we get some idea about what is popular, what's not so much, some feedback to us so we know what to try to target for the following talks. So please do scan that in. Next week at Grand Rounds, Pavan Bangalore, who is one of the sustainability leads for NHS Tayside, is going to come back. He's given 2 or 3 talks that you can find on the sustainability playlist on our YouTube channel. He's going to come and give an update on the sustainability projects that are happening all across NHS Tayside, from the very visible green-topped plastic bins where you can recycle your plastics and cardboards, through to the ongoing mission to get rid of desflurane from theatres, which has pretty much happened, to be honest, and that's a big issue, and the reduction in nitrous oxide use, and some new things, including more on inhalers, a thing dear to my heart, sustainable travel, cycling to work, and a whole raft of other things. So if you're interested in sustainability, and these days who isn't, then please come to Grand House next week. Rory, thank you again so much. Really fascinating talk, and we're so lucky here in Tayside to have such expertise in these areas, and to have you and to speak about earlier in the year, and you speak now. I think we're really blessed with this. It's really cutting edge stuff from true experts in the field. So thank you very much. And the rest of you, have a good weekend when it comes, and I'll see you again next week.